This is a case of antegrade flexi URS for a difficult upper ureteric stone. This was a complex patient who was 36-year-old. He had multiple problems. One was polycystic kidney disease, because of that chronic kidney disease, and then he had a childhood history of stricture urethra where perineal ureterostomy was done at the age of 13. Then he had stenosis of the ureterostomy and he was living with it with dilatations and then lost for follow-up. Now he presented with right upper ureteric calculus with pyonephrosis and severe urosepsis. His creatinine was 8 and the sepsis was quite severe, so we did a percutaneous nephrostomy, ultrasound guided. So this is the ultrasound showing the polycystic kidneys. After PCN, around 300 ml of frank pus drained. This is the CT after PCN. You can see the right kidney is the better functioning kidney in this patient. So we planned for an definitive removal of the stone after 3 weeks when the patient's nadir creatinine was around 2.4 and he had recovered well. But during the procedure, when we did the ureteroscopy, the ureterostomy was quite stenosed and the urethra was very stenosed and fibrotic. It was rock hard. We could hardly dilate it above 14 French. And so we did a cystoscopy using a mini nephroscope, and still we couldn't identify the ureteric orifice because the bladder was also quite deformed and the ureteric orifice was a little lateral, and especially the scope movement was very much restricted laterally because of the fibrosed and scarred hard urethra. So we thought we will change the procedure to a supine PCNL. See, this is the fibrosed urethra after dilatation, and we changed the leg of the patient alone, and then we could proceed with the supine PCNL. We dilated the same tract to mini perc size of 16 French. This was a middle calyceal entry, and we did a nephroscope. But unfortunately, because of the previous pyonephrosis and the perinephric fibrosis and the polycystic kidney, we could not reach the stone with the mini nephroscope. So we thought we will insert a flexible ureteroscope from above itself. So the flexible ureteroscope was inserted from above, and here we could easily identify the stone at the upper ureter, and we started lithotripsy using thulium fiber laser. So the trick with the antegrade flexi URS is it is not straightforward, unlike the retrograde approach using a flexi URS, because the lumen of the amplathe sheath is quite big. The scope keeps dangling, and also a lot of scope lies outside the body. So the maneuverability is quite tricky. Also, the movements are not fine. So we have to be very careful, especially if you are working in the ureter, not to injure the ureteric mucosa. The rest of the lithotripsy is quite straightforward. We tried to dust the stone with a setting of 1 joule and 8 hertz. We thought any remaining fragments at the end we will remove with the basket. So this is the classical lithotripsy. Always be at the center of the stone when you are working in the ureter and go towards the periphery. Unlike in when working in the kidney, we do a circumferential painting. The view in these disposable scopes are quite excellent, so that we can do a safe lithotripsy in such challenging situations without any injury to the ureteric mucosa. The advantage of supine PCNL here is this patient, once we thought of changing the procedure from RIRS to PCNL, we just had to extend his legs and just turn him around, and we could proceed it with the same spinal anesthesia. We need not convert it to a general anesthesia and complete the procedure comfortably. Once in a while, we encounter such patients where the retrograde approach is not possible. and we have to do an antegrade approach. Even guide wire would not be possible across the stone in some cases. Some cases like this, we cannot identify the ureteric orifice. In such situations, supine PCNL comes in quite handy, and if we are having a flexible ureteroscope, you can do an antegrade flexi URS to clear the stone if the stone is quite low in the ureter. Usually, in such upper ureteric stone in the middle calyx entry, usually we will be able to reach the stone with the rigid nephroscopes itself. But in this case, because of previous pyonephrosis and the polycystic kidney, the scope maneuverability was limited, and especially we took care not to avoid, not to cause any torque, because already he is a CKD patient and any undue bleeding will be catastrophic in this patient. In fact, in the end, we had done an SPC for this patient, and actually, during stent removal, the urethra was still stenosed, and we could remove it only through the SPC tract. Now he is on SPC and on follow up. He is planned for definitive management of the urethra, which is quite a big challenge next. These are the final fragments being done. Now a basket is inserted. This is a end circle basket being inserted, and the last few fragments are basketed out. Doing laser lithotripsy for these final fragments in the ureter is not safe, so better to basket it out. After clearing all fragments, we could reach all down up to the bladder from above, so that no fragment is missed. Here we have reached all the way down to the bladder. Finally, the stent is placed antegradely in the routine manner. Thank you.